Can you guys hear me now? I'll move it there. All right, so my name is Nicole Herndon. I'm one of the speech-language pathologists at the Movement Disorders Clinic, and I work alongside Karen Hegland. She's also a clinician there, but she is also a researcher at the University of Florida. So today we're going to talk about updates in speech and swallowing in Parkinson's disease. So I'm going to go over our typical evaluations that we do at the center, as well as changes that you may expect in speech and swallowing in Parkinson's disease. And then she's going to go over some of the updates in speech and swallowing as they relate to medication and surgery with deep brain stimulation. All right, so first let's talk about speech. So speech is the power of expressing or communicating thoughts by speaking and the exchange of spoken words. So if you think about things that you do day to day, you call and make an appointment, you're talking with your spouse, you're talking with your family, friends, you're speaking, you're exchanging words, you're talking about how you're feeling, you're sharing ideas and things like that. And so it's very, very important that you can express yourself clearly so that others can understand you. And it's also very important for social participation. So in terms of speech, it includes the coordination of 4 subsystems. The first one is the respiratory system. So you take a deep breath in with your diaphragm and some of the other muscles, and then you exhale for speech. The next one is the phonatory system. So if you put your hand up to your throat and you say like ah or something like that, you can feel some vibration. That is your larynx. So that's the system that helps kind of turn your voice on. And then the next 2 systems, the articulatory system and the resonatory system, kind of help shape that sound. So you can produce voicing, but what turns it into different speech sounds like the pa, the la, the ta, the ka, are different kind of, or na, are the articulatory and resonatory systems. So in terms of our speech evaluation that we do at the center, we listen to you talk. So we do various tasks that listen to the different subsystems that I previously talked about, so that we can best figure out what's kind of going to give you the biggest bang for your buck in terms of strategies. So what are we hearing that is impacting you most in terms of speech intelligibility or you being able to express yourself with those spoken words with other people, your communication partner? Sometimes we'll do a questionnaire, so sometimes we're seeing you in that clinical setting that's nice and quiet. We are face-to-face. We have some experience with patients with dysarthria, so we aren't maybe a familiar listener to you, but we're not an unfamiliar listener. So I like to give out this questionnaire to kind of see different scenarios that you might be speaking in day to day. So speaking on the telephone, speaking with familiar, unfamiliar listeners in a noisy room like a restaurant, and how that impacts you being able to get your message across to others. And then lastly, we might take some maximum expiratory pressures. So with this, for those of you that have seen us in clinic and we have done this, we take a fancy little gadget called a manometer, and we have you breathe into it as hard and fast as you can. And this is measuring how much air you can forcefully exhale in about 1 to 2 seconds. And sometimes we use this measurement to see, okay, where are you in your normal values? Sometimes we have patients that are speaking a little bit softer, but they have great numbers on this, so we can see, okay, they have a good respiratory system, they have good respiratory support, maybe we just need to target them using that more frequently. And then we'll use this measurement sometimes to set that fancy EMST device that some of you may have, which has been shown to help cough, speech, and swallow function. So some of the speech changes that you see in Parkinson's disease are dysarthria. So at least 75% of people with Parkinson's disease will experience some sort of speech change. The most common ones are going to be reduced breath support, reduced volume is a pretty frequent one, hoarse or breathy vocal quality. More typically than not, that's because you're taking a shallower breath, so you don't have enough air to go through the vocal folds to give it that nice quality that you always used to have. Short rest is a fast speech or faster rate of speech. So sometimes at the end of the sentence, that rate will speed up, or maybe just your consistent fast rate of speech is now going to be your new rate. Reduced clarity, so if you're going faster, you have a reduced range of motion of the lips, the tongue, the clarity may go down because of that. So if you can move faster, it's going to just be less precise. reduced inflection or prosody, so maybe not monotone, but a little bit more flat than it used to be. Hypernasal resonance, so maybe a little bit of extra air going through the nose. It's usually not something super noticeable to other people, but I always like to tell patients that we like to be nitpicky about your speech, to pick up on little things to make sure it's not going to be impacting your speech completely or people's understanding of it. And then lastly, stuttering. We don't see this too often, but it definitely can be present in patients with Parkinson's disease. So next, let's talk about swallow. So swallowing requires the coordination of many muscles, about 50 paired muscle groups, and it includes 3 stages: the oral stage, so the mouth, the pharyngeal stage, the throat, and the esophageal stage, the esophagus. So we are concerned about dysphagia, which is when there's a difficulty managing food, liquid, even saliva when you go to swallow it. So it enters the mouth, and what happens to it then? So with our studies, we like to do an X-ray video swallow study. I'll get to that in a second, because we just don't know. If you were to take a sip of your water and close your lips, I can only make assumptions about what you might be doing. I really don't know. I don't have X-ray vision, unfortunately. So consequences of dysphagia are going to be malnutrition, dehydration, choking, so you might require that Heimlich maneuver, aspiration pneumonia. It's one of the leading causes of death in Parkinson's, so it's why we're trying to get ahead of any large changes so that we can prevent it. Taking longer to eat a meal. So let's go back to kind of the social participation. Meals are very social. You often eat them with at least one other person. Maybe you meet up with a group of your friends and you go out to eat. So if it's taking you longer to eat, it might be embarrassing. If you're experiencing drooling, that also might be embarrassing. You might want to start to avoid, hanging out with different people, and we want to make sure that that doesn't happen. So swallow changes in Parkinson's disease occur in up to 80% of them. So it varies in terms of severity and the deficit, so I'll go over a few of those here, but we really just don't know until we do our swallowing evaluation. So the first one is swallow discoordination. So in a second, I'm going to show you how quickly a swallow happens, and you'll see that if one thing kind of is out of tune, it's not working like it should, it's maybe just not as quick as it should move, it could make an impact on your swallow. Slowed oral transit time to the pharynx, meaning from your mouth to your throat. So we'll see tongue pumping or rocking. That is one of the hallmarks of the oral phases in Parkinson's disease. It's where it kind of takes a few extra pumps to get the food back. Xerostomia, so dry mouth, or sialorrhea, which is extra saliva. So more often than not, it's the dry mouth that is giving patients difficulty. So if they just have a dry mouth, we gave them a cookie or something to swallow, and they say, I can't swallow it, I need a drink of water. My mouth is too dry, it's just sticking in there. Impaired airway protection, so we're worried about aspiration. So we're looking to see if you aspirate, because we're concerned that either there's a reduced cough response, so something goes down the wrong way, and you don't cough, or a weak or absent ability to cough. So we talked about that respiratory system for speech, but it also plays an important role in swallowing. Coughing helps eject any material that went into the airway back out. My colleague Karen has done a lot of research on Parkinson's and cough, and continues to do research in that area. So if you're interested, you can email her after. And we're most concerned about aspiration pneumonia. So aspiration in and of itself doesn't necessarily mean that you're going to get aspiration pneumonia. There's a few things that can reduce your risk, including good oral care. We always promote brushing your teeth at least 2 to 3 times a day. So that includes the tongue, the gums, and the teeth. So the tongue has a majority of bacteria on it. We want to make sure that it's not sitting around there when you go swallow saliva, food, liquid. If it were to go down the wrong way, that bacteria is attached to it. So getting that bacteria out can really reduce your chances of aspiration pneumonia. Being mobile, trying to stay active, not smoking, and feeding yourself are all good positive indicators to reduce your risk of aspiration pneumonia as well. Impaired efficiency. So this I'm primarily talking about in the throat. So if something kind of sticks in your throat, sometimes we'll have patients kind of point and say they feel like it's sticking around here. We'll try and figure out why that's happening and then give you a strategy for it if we feel like it's impacting your swallow. There can be a few reasons that is caused by it, so we just don't know how to target it until we really get that X-ray video swallow study. And then lastly, esophageal dysmotility, so stuff sticking in the esophagus. So maybe it's just not going down as quickly as it used to, maybe some reflux is happening. So we're concerned about that because if stuff starts to come back up. So if it comes back up and gets into that airway or kind of just causes discomfort, you don't want to eat because of it, then that's a concern of ours. So for our swallowing evaluation, we do a rehab barium swallow study, and it's considered the gold standard in oropharyngeal swallowing assessment. So oropharyngeal, mouth and the throat. And so we're looking at those two phases. Sometimes we will do a scan of the esophageal phase of the swallow just to kind of check it out, but it's not really our area of expertise. We always kind of defer to an ENT or gastroenterologist for that. So here is our version of the swallow study. So this is me swallowing thin liquid, and then the one beside it is the solid. So you'll see me chew a cookie and then swallow it. So you can see there my chin, and then you can see my mouth. It's kind of hard to see both of those. When I chew, it'll be a little bit easier. And then you can just see how quickly it happens. So you'll see how everything kind of goes to the tube in the back, which is the esophagus, and bypasses that airway, which is in the front. So this is that thin liquid. So it's kind of like a water or a coffee. And then the next one, you'll see me chew the graham cracker. It has some barium on it so that we can see it. And then I'll go ahead and swallow it. So you can just see how quickly all of this happens and why it's so important for us to kind of get this view to figure out what exercises we can give you, what strategies would be most helpful, and what really is going on, since we can't rely on cough, right? Since that cough response may not be there if stuff were to be going down the wrong way. So we might give you compensatory strategies. So maybe we'll say add sauces and gravies, alternate bites of food and a sip of liquid, single sips, small sips, something like that. Postural changes. So sometimes we'll do a head turn, we'll do a chin tuck, or a diet modification, so thickening liquids, pureed or softer diets. We always try and kind of go from the top down. So diet changes is going to be our kind of last approach. We know how much that impacts quality of life. Thickened liquids are just not what you're used to. We're worried about a few other risk factors with that as well. But really, all of these things need to be seen on a rehab barium swallow study for us to be able to figure out what's going to help you. And we always like to look at the risk factors, if you've had pneumonia, if you haven't had pneumonia, what your cough is like, your quality of life, and your desires, and your family's desires. So do you want to continue to eat your same meals, even if it gives you some problems? And we can just try and work with you to make it as safe as possible. Are you open to thickening your liquids if that needs done, or doing a postural change if you're able to remember to do those things? And I always like to have this saying, we make recommendations, and along with the patient and family, we make decisions. So it's not going to be, we go tell you what you must do. We'll take, your wishes into account, because I think that's very important. I always we have some grad students with us in clinic, and I always have them try the thickened liquids, the barium, and just say, would you want to be drinking this all day long? So, I think it's important to really think about what a patient wants. And also, if you give them a recommendation for thickened liquids and they don't follow it, then what's going to be the next safest approach? So any questions about speech, swallow changes in Parkinson's, our evaluation, anything like that? Any questions before we move on? No? All right, so I'm going to let Karen come on up and talk about the updates in speech and swallow on pharmacological and surgical interventions. And then we'll also have questions at the end. So if something pops up into your mind halfway through Karen's next presentation, you can ask us at the end.
Good morning. It's nice to see everybody here, lots of familiar faces. We did not plan the outfit thing. That was completely a coincidence. But it seems to be a theme, because I've seen some other ladies with the blue-black thing going on today. So I don't know what it is about that and today. So thank you for being here. I am going to go over some topics based on just questions I get asked a lot in clinic, which is, will my medications affect my speech, voice, or swallow? if I get deep brain stimulation therapy, will that affect my speech, voice, or swallow? So it's been kind of fun diving into this literature to get myself current on what's been done. So I'm kind of dividing these into 3 different functions, and that's just based on the way that people have done the research. So there's researchers that look at specific parameters of voice function, of speech, articulation, and prosody, and then also of swallow. So that's kind of why these slides are grouped the way that they are. And so the other thing that I want to say before I start going over this material is that I know that there are a lot of different medications that you can take for Parkinson's disease. What I am presenting to you is not broken down by medication type. So this could include agonists or any different sort of combination of things that you might be on. There's a lot of information out there, but there's just not a lot of information on one particular type of drug, so this is everything included. So a few studies have looked at the effects on voice. Several of them has found that there were no change. Okay, so when they made measures of vocal function with people on or off medications, in some studies they did brand new patients who had never been on a medication, took those measures and then took them again after they started medications. Some of the studies found no change in the different things that they looked at. There have been some studies that have found an improvement in voice function. They have to do mainly with the quality of voice, so they can make measures of how variable your voice is, looking at pitch and frequency kinds of changes just in a sustained phonation. And some studies did find that that became more stable, which would be perceptually an improved voice quality. There have been some studies that have found increases in loudness, which we know is important because decreased loudness is one of the hallmark features of speech in Parkinson's disease. Changes in pitch, specifically elevating the pitch. Sometimes the pitch can actually decrease in Parkinson's disease. And then improvements in prosody. So when we say prosody, what we mean is the melodic contour of speech, right? That natural rise and fall in pitch that gives kind of extra meaning, right? It's what lets you know if somebody is saying something in a happy way or a sad way. And so there were some improvements in prosody that have been found when on the Parkinson's medications. Looking more globally at speech, so more specifically considering things like articulatory precision and those kinds of things, there's not quite as much data on these because it's just kind of more of a hodgepodge of parameters that people have looked at. One specific thing that has been found to potentially improve with medication is this concept of fluency. So when I say disfluency in speech, what I'm really talking about is stutter-like behaviors. So things like sound and syllable repetition, prolongations, inaudible pauses, so things that kind of disrupt the flow of speech. So there have been some studies that have found reduction in the amount of disfluencies when on medication. The caveat to that was was specifically for the subgroup of patients in the study that exhibited more disfluencies to begin with. So people who didn't have many disfluencies really didn't look different on medication, but people who did have those improved on medication. There has been some research that's actually found that there's increased variability of speech rate when on medication. Now, why is that a bad thing? Think about kind of having some speech that's sort of a normal rate, and that's just how many words per minute, and then you suddenly speed way up, and those sounds kind of get jarbled together. They're not as clear. So that can have a negative effect on intelligibility. So we really don't want to see a lot of variability in speech rate. We want it to kind of fall in a normal zone in terms of the number of words per minute that are produced. And then there have been studies that have found no change. Okay, so speech intelligibility, which is kind of just an overall metric of how effectively you're able to get the message across. Speaking rate in some studies didn't change, prosody in some studies didn't change, and disfluencies didn't change. So there's not really a consensus on exactly what medications do to speech. Some things may get better, some things may get worse, some may not change. And again, if we really had the resources to start to look at this by medication type, maybe we would see the differences in medication explain some of the variability that we see in the effect on speech. Swallow and PD. There is absolutely no consensus that anything about swallowing changes with PD medication. So empirically, in terms of what's been published, I get that. I can tell you anecdotally that sometimes that's not necessarily true. Sometimes, for example, if there's some sort of upper body tremor or tremor in the trunk that is having a negative effect on swallowing, having that taken care of or addressed can actually alleviate that effect on the swallow. So it's not a direct effect to swallow physiology, but it's kind of alleviating something else that's affecting swallow. So that's just one consideration in terms of the medication effect on swallowing. Okay, so that's kind of what we know about meds and speech parameters. Let's look at the effects of DBS. Now, I'm sure everybody in this room, being that you are kind of pros at this point, knows what deep brain stimulation therapy is. Just to kind of give you the spoiler up front, the consensus is that there is not a consensus on what exactly it does to speech or swallowing. I get asked this question a lot because I see any of the patients that are coming through that are going through our fast track process. I do the speech and swallow evaluation, so I get asked these questions all the time. So one thing to consider. For Parkinson's disease, there are two primary sites that we go to in terms of the deep brain stimulation: the subthalamic nucleus, or STN, and the globus pallidus internal segment, or the GPI. We can do one side or two sides, or there might be other combinations where maybe one side is an STN, another side's a GPI. Some people come in from other sites with various combinations, so there's a lot of variability out there. I can tell you the majority of research available right now has been done on the effects of bilateral STN. The reason for that is that if you look at centers across the world, that's just the most common type of surgery that people end up with. Okay, so most of the things that I'm going to present in the next few slides is on patients who have had bilateral STN therapy or surgery. Okay, so let's look at voice first. There have been some studies, and again, this is in bilateral STN, that there is amelioration of voice tremor when it is occurring secondary to body tremor. So just like I told you about swallowing, if you have this other thing that's affecting voice and you can take care of that, certainly you're going to get an improvement on voice. This is not referring to somebody who has a specific voice tremor, like some folks with essential tremor might have. This isn't going to ameliorate that type of voice tremor. This is specifically when the voice is affected by your other hyperkinetic movements. On kind of the more negative side, there have been lots of findings that suggest bilateral STN or GPI surgery have the potential to increase the strain in the larynx, which is your voice box, and the result of that is kind of this spastic or very, very effortful sounding voice quality. We think this is due to a combination of reduced, what we call glottal closure, so that just means your chords should come together at midline when you're producing voice. So when that's reduced, what researchers have shown is that all of the muscles that are right above the actual vocal cords try to compensate. So they're really, really straining to try to help produce that voice, and that's what kind of gives this spastic or strained quality. So that's a change that we would consider kind of a negative change to voice. In terms of speech, I'm sorry that's so small. It didn't look so small on my computer screen. I can go through it, though, so you know what the words are that are up there. So there have been some studies that have suggested that hypokinesia, or those small movements that Nicole was talking about for speech, actually improve following bilateral STN surgery. So the range of motion improves, and that has really positive effects on the rate of speech and also the clarity of your articulation. There's also been some studies that have shown, again, that prosody, that melodic contour, might improve after DBS. There have been other studies, of course, because I told you there's no consensus, that there's no change. So there was a study that looked at jaw opening, And particularly with a GPI target, they didn't find any difference in kind of that range of motion for the jaw. And then, like I said, there's a lot of studies that have indicated that bilateral surgery, particularly to the STN, might impart that spasticity. So same idea as what I was just mentioning for the voice. When you get spasticity, you get extra muscle activity, and it makes speech just very, very effortful, is kind of the effect of that. Some studies have found that articulatory imprecision, so how clear your sounds are, reduces a little bit. And then there was a study that showed that the jaw control, so that opening was actually a little bit worse with the STN, and that was compared to the GPI. So kind of a hodgepodge of findings there. For swallowing, like I said, the consensus is still out, but we've done a study a few years ago here. It was retrospective, and then we followed it up with a prospective study that found, just for unilateral surgeries, so not bilateral, that unilateral STN DBS actually had an effect where swallowing got worse afterwards. So what that meant was that things were more likely to go down the wrong pipe more often. Whereas folks that had the unilateral GPI surgery had no change to their swallow function. And that second point is in line with other studies that have found bilateral STN and GPI DBS also didn't have an effect on swallowing function. So the jury's still out on that one. All right, so what are the take-home messages here? First of all, and caveats. Okay, a few things I didn't mention as I was going through there. First of all, the positive effects of medication seems to relate primarily to voice and fluency. Those are the two findings that were kind of the common threads through a lot of those studies. But the thing is that they seem to be sort of present only at earlier stages in the disease. So a lot of those studies looked at people who were just presenting, just diagnosed, hadn't been on any PD medications before, and when they looked at those measures before they started medication and after they started medication, that's where they saw the most robust differences. So not for somebody that's been on medication for, let's say, 10 years, and then they looked on versus off. That wasn't the group that showed the improvement. It was those early folks. So that's kind of the caveat to that one. There seem to be maybe some positive effects on DBS to voice, but they seem to be pretty minimal, if any. And there's a big difference between the unilateral versus the bilateral findings. Like I said, most of the research to date has been on bilateral STN, so we really, really need to learn more about the unilateral surgeries and then also the GPI surgeries in terms of speech and swallowing. 3, there is increased likelihood of worsening effects to speech or swallow following DBS if you start off more impaired. So I know sometimes people will ask, well, why do I have to have this evaluated before I can have surgery? It's because if your function is severely impaired, there's a much higher likelihood based on the research that it's going to get even worse following the surgery. So we really want to make sure that we know where you stand pre-surgically. People who don't have speech or swallowing problems to begin with typically don't get major problems after surgery. If there are changes, they tend to be more subtle. I didn't mention this, and you might be wondering why unilateral versus bilateral would make a difference. Well, it just so happens that the muscles in your head and neck receive their motor innervation from both sides of the head, okay? So you get bilateral innervation to those muscles for the most part. There are a few exceptions. That's important because if you have one lead there that's kind of having maybe an effect on some of those muscles, you've got a backup, right? The other side is still there. It's still working normally. When you put both leads there, you've taken away your backup, okay? So when there is sort of stimulation-induced maybe some interruption in those signals, it's going to happen primarily with the bilateral placement as opposed to the unilateral placement, just because of that double-sided innervation of your head and neck muscles. And lastly, there have been studies that have shown when you go through your programming for your device, if the lower levels of amplitude and frequency stimulation can potentially ameliorate some of the effects to speech and swallowing. So there have been a lot of studies looking at low, so around 60 hertz stimulation as compared to high 130 hertz stimulation, and found significant differences there. So it is incredibly important, not just for speech and swallowing, but for all of the function, to work closely with the programmer to find settings that have the right balance of capturing your other motor symptoms, but also not having a deleterious effect on speech and swallowing. This is a reference list. There will be a test on that. I know you can all see it very well. And otherwise, we are happy to take questions. Nicole and my email addresses are both up there. You're welcome to jot those down. Contact us afterwards with questions if you have them. Or if you're interested in any of our current research protocols, please reach out. Thank you. Yes. So the involvement of the sensory system, the sensory nerves, yeah, so that's a really great question. That's something I'm really interested in. There does seem to be a role for blunted sensation in certain areas of the throat and some of the changes that we see to speech function. So we've been doing an ongoing study looking at respiratory sensation and cough sensation and how that relates to the motor outcomes. And we do see that there is a relationship between reduced sensation in the mouth and the throat and changes to speech and swallowing. So we're trying to learn more about that, figure out if there are any ways that we can kind of target those sensory aspects. It's hard to study. Motor's easy, right? You can just measure movement. Sensory's tricky. So, but we're really very interested in that. And actually, one of our major ongoing studies is looking exactly at that. Yes. Yes, so the question was if I could talk a little bit about the studies that we've done on cough and the importance of keeping this muscle strength for cough. So cough, a lot of people think cough is a bad thing. Cough is your friend, right? If something goes down the wrong pipe, cough is what's going to get it back up. So we really want to make sure that you have adequate airway defense options, right? Everybody has something go down the wrong pipe every once in a while. The trick is that we can usually get it back out. So what we found is that some of the muscles that are responsible for creating an effective cough are a little bit weaker in people with Parkinson's disease. And over time, that sensory component seems to also kind of get diminished. And so then you have this, okay, something's going to go down the wrong pipe. If it does, I might not be strong enough to get it out, or I might not even sense that it goes down the wrong pipe. Okay, so we've been really interested in these things, and we found that there are a couple of ways that we can actually improve the sensitivity and the strength of cough. Nicole mentioned the expiratory muscle strength training device. That's a device that directly trains the muscles that help you expel air from your lungs. Really important for cough. So we've been doing some research and found increased cough strength when you train with that device over a period of 5 weeks. So we do now, even outside of our research studies, routinely recommend that device to people. It also has shown some positive effects for swallowing safety and speech. We're just wrapping up a clinical trial where we looked at a way to give small amounts of stimulation to the upper airway to see if we could help improve cough sensitivity. That data is being analyzed now, but I can tell you preliminarily, it looks like we were able to enhance sensitivity a little bit. It didn't have as robust a response to the effectiveness, so the strength, which makes sense because we weren't focusing on strength, but it does seem to have an improvement in the sensitivity. So like I said, that data analysis is still kind of ongoing, but that's what the trend looks like so far. Other questions? Yes. say that last part one more time? Oh, okay, so the question was about constipation, which is the wrong end of the body for me, right? I stay up here. But the question was, does the EMST device, because it's helping with those muscles that are important for bearing down, have any effect on that? And the answer is, I have no idea. I'm sorry. That would be a really new area of research for me.
Per Chris Sapienza, who was part of the team who developed it, I was recently listening to one of her webinars, and she said that the highest rating on the EMST, which is 150 centimeters of water for those of you who have it, is less than a bowel movement. So I don't think it would really have any positive impact on it, but I don't think anyone's ever looked at it. So who knows?
That's a good point, yeah. Other questions? All right, well, like I said, jot down our email addresses. If you think of other questions, if you want to know more about the research that we do, please feel free to reach out. Thanks.